This is my Prothsfolio, and in it I'm just going to discuss the activities that we were able to do this semester and different techniques we were able to learn, how to think like prosthodontists, etc. I do want to start out with what it's like to be a prosthodontist. I'll go into the patient aspect soon enough, but I did say that I got a lot of insight on how creative you have to be. You have to fill in the blanks. Patients will come in with complaints that aren't just something you can detect on an x-ray, aren't just something that you can see in the soft tissues of their mouth and diagnose. Sometimes their dentures are just bothering them, and you have to be creative and come up with a way that will fix whatever it is, and sometimes they even have a hard time describing it. So, it's a lot of problem solving and creativity, I'll just say that much. Um, we did an activity at the beginning of the semester called Toasters and Toilets, where you were given a basic household item, like a toaster or a toilet, and you have to come up with a problem with that item or something you would like to improve, and B, what you would do to improve it. And at first, it was an interesting introduction to the semester. I won't say that it was like weird or anything. I was just more intrigued. Didn't know where it was going, and it turns out that I could totally understand where our professor was coming from. You're given something, how are you going to improve it? And especially if you want to be an innovative prosthodontist, you are given a technique, for example, on how to make a denture. How are you going to make that denture better? What techniques are you going to improve to make things more efficient, cost effective, and more aesthetically pleasing if possible? So that creativity, it takes a special kind of person to be able to do that as a prosthodontist. I don't know if I'm cut out for it, but I had a lot of fun this semester, at least getting familiar with the materials and even empathizing with patients. And I'm about to show you a video where we made, I don't know why I didn't get a picture of it, by the way. I'm sorry, I don't have a picture of my selfie denture, but that's what they were called. It was just a acrylic piece that we made to form the roofs of our mouths, and it helped us empathize just a little bit, where edentulous patients with dentures are coming from when they say that sometimes it's hard to eat. We watched several videos about patients who had a hard time on the 4th of July when they made chicken, and they just really wanted to be able to eat chicken. And it's something that you don't really understand until you go through it yourself. And like I said, we, on a very small scale, are able to empathize. But I'll show you my video describing my experience. And yeah, I hope you enjoy. Okay, so this is round 2 of my selfie denture video because my other one was too long to send, so I'm going to be talking fast and keep this short. Sorry, it's not going to be as exciting as yours. So what problems did you identify while wearing your selfie denture, and what problems do denture wearers face? Mine was really gross tasting. It was awful. Didn't get a whole lot better in the 24 hours. It did get better, but not by a lot. I talked really funny, Miley Cyrus status, where people can't really tell if I have dentures or not, and I was just talking weird. Had to take it out a few times for people to understand me. Eating was a problem. Food would kind of get stuck up underneath it, and I tried to suck it back in, but yeah, it was an issue. What improvements did you want so that your selfie denture experience would have been better, and what could make denture wearers' experiences better? Again, if it tasted okay, not a big issue. If it was aesthetically pleasing, a lot better. And the whole food thing, that one's really hard. I don't know how you can fix that, honestly. It's just bad all around. They'll have to take their dentures out if they go to a restaurant, but chewing on candy like I was really hard. So I don't know if that could be an issue that's taken care of. That would be great. Yeah, anyway, there you go. So I hope you enjoyed that video. Apparently 1,500 users on YouTube. I didn't think anyone was going to see it, hence the lack of makeup, hair on top of the head, and the hoodie shot. But apparently there are people out there watching it, and hopefully that you enjoyed it as much as they have. So next I would like to talk about different devices that people can wear, prosthetic pieces. I think most people, when they think of dentures, they just think of the acrylic lying right onto the soft tissue, which is common. A lot of patients have those. But there is also another kind of denture that has implants, that is attached by implantation. And you can have those around the canines, the implants of the canines, maxillary and mandibular. And they make for an anchor, and the denture just snaps right on. Here is a picture of that. So clearly it's going to be cleaner than that. That was after we had already drilled out the pieces, but you get the idea. There are two implants anchoring the denture in. I think sometimes you can have four implants, but there is another kind called a bar over a denture, where it's the same idea, implants, but there's a bar connecting them so that the tension or pressure is evenly distributed across the bar. It's not just on one implant or the other. There's a more even distribution across the bar. And patients have reported in some of the videos that we watch that there's less rocking that happens with that, which makes sense. So those are some other options patients have, along with individual implants. There are partial dentures. There's a whole bunch of options that patients have. So it sounds like that the implants are a very great option for patients, and I think they are. There are complications that come along with them, though. We were given an article called The Denture Dogma, which discussed, a whole range of items when it comes to dentures and prosthetics, but there was a section talking about implant failure and prosthetic complications. And just that it says that several studies have demonstrated that complications after implant treatment are common, and repair and remaking of and reconstructions can be both time consuming and costly. Um, that is something to consider when addressing your patient's issues. You can't just go right along and say, yeah, of course, an implant is the best thing for you. It does differ, and that is why some patients have to just go for the acrylic directly onto the soft tissue with nothing anchoring it. Okay, so now let's actually talk about making a denture. I want to talk about the concepts behind it and the artistic aspect of it, but also how you actually make the denture, the materials involved, and the different steps. Okay, so first you want to take an impression of your edentulous patient with alginate, then pour it up with plaster, and then you place triad over the palate and almost up to the vestibule. Add wax for your Wayne Newton rim, and then you try that wax rim directly into the patient, like here, and start with your dress to the nines. Okay, so let me actually describe to you now what the dress to the nines is. And it is derived from what we call the theory of idealism. And that is just essentially the ability that humans have to be able to identify what is exactly attractive about someone, or at least their face. It's talking about ideal proportions of where the teeth are lined up with the nose, the eyes, the whole face, everything. And they've found that there are general patterns that look best on people, and that is what is described in Dress to the Nines. And I'll just go over those really fast with you. I won't go into too much detail, but we tried that with Ross and Hermie, our live patients that you saw pictures of and will see more of, who were fabulous, by the way, and we're so thankful that they were able to help us. And we were able to make some really great dentures for them, I think. So just the nine steps that you do and different markings you make on the wax for setting teeth, essentially, and when you do the wax fitting for them. So number 1, buccolingual position of maxillary central incisors. Just make sure, the patient will be turned to the side, make sure that it's not flared out, that it's actually pointing down to the bottom of the inside lower lip. Number 2, incisal length of maxillary central incisors. Just make sure, not too much gums is showing, that they're not really long, almost horse teeth. That's something you can do visually, just have them smile. See where the line is with the lip, also in repose, to make sure, just with relaxed mouth, to make sure that you have just enough showing. And in a younger patient, it's more just like a 1 millimeter of the canines, a couple millimeters of the upper teeth or maxillary teeth. And in older people, their lip tends to hang down just a little bit more, so they won't be showing as many teeth or as much of their teeth. Number 3, maxillary occlusal plane angle. Again, patient is turned to the side. We want their occlusal plane of the maxillary to be matched up with what we call Camper's plane. From the nose to the trachea of the ear, that imaginary line, it's going to match up with that. Number 4, buccal corridor. Patient smiles. You want the edge of these teeth to be lining up to the teeth or to the eyes, not too narrow of an arch, but also not way too wide. Number 5, maxillary midline position. If you haven't seen Tom Cruise's midline, check it out. You can tell it's off, and it's just make sure that your patient's midline is up with the nose, philtrum, frenum, everything. Also the angle. You don't want the teeth to be crooked. Okay, step number 7, the zenith line. Tops of the maxillary teeth, the arc that they make back, your upper lip should also follow that line. Number 8, the buccal lingual position of mandibular central incisors. Okay, so let's say these are your lower teeth, maxillary teeth. You want them to be maybe 2 millimeters behind. You don't want a class 2 completely. You don't want a class 3 either. Class 1 is ideal, which is about that position. Same thing with step number 9, incisal length of mandibular central incisors. You don't want the upper teeth to be completely overlapped, but you also don't want an open bite. Just probably 2 millimeter overlap. So that's dress to the nines in a nutshell. I think that people can make really functional, great dentures without having everything perfect and aesthetically pleasing. But another part of denture dogma, the article I mentioned before, it says, it's a part that stood out to me and says, an extensive review of the literature on complete denture occlusion concluded, despite its biomechanical importance, occlusion, as well as the technical quality of the denture, plays only a minor role in determining success or failure of a denture treatment. A number of psychosocial factors are likely to be more important than prosthodontic features for a positive outcome. And that to me just says, it might have perfect occlusion, everything might be functionally well, but at the end of the day, a lot of it is just psychosocial. And I think that Dress to the Nines allows for that part to give them a really strong, great looking denture. And we have found that to be true in our live patient experiences. And now that we have marked the wax after our Dress to the Nines, it's time to take the bite registration so that we can set the teeth. So again, like I said before, you use Dress to the Nines to set teeth. You know where the midline is. You know how high the teeth are supposed to be from the line you made according to the zenith line. You know the occlusal plane. You've melted the wax down to the occlusal plane that matches Kemper's plane. And you go ahead. We read an article by Wiscott and Belser that describes different principles in occlusion. And essentially, you want adequate anterior guidance. If you have proper occlusion with that, it can satisfy functional requirements, also satisfy aesthetic demands. We found that the canines are very important in aesthetics, but also in the anterior guidance, and ensures occlusal stability. You also don't have to have the tripodizing in setting the teeth, where basically the cusps are like perfectly aligned and intertwined. You do want them to be in a class 1, for example, but you don't have to have them all completely together. The article also says it doesn't mean that the presence of a large number of tooth contacts is necessarily harmful, but that they shouldn't be striven for either. Neither during the occlusal adjustment nor during restorative procedures. So just keep that in mind when you're setting teeth, not perfect occlusion. You do also have to keep in mind the arches. So even though you really, really, really want to set the teeth into like a perfect class 1, you have to keep in mind where their arch is at the time. Here's a little picture where I started out with a really great maxillary arch, and then I tried to set the mandibular. Keep in mind my patient is a class 3. I tried to set the mandibular to the maxillary arch, in a class one, and it just gave so much extra down here that it just looked ridiculous. Here it is. On our actual patient, though, we were able to set the teeth nicely. One of the articles did state that you didn't necessarily need a face bow for that, which is good to place on an articulator. So we just put it on the standard one. Simple 2 pieces. You put the teeth on, place the teeth according to the dress of the nines, and here is Ross and Hermes' final experience. After we've set the teeth, you want to try them into the patient, make sure that the patient likes them. Hermes liked mine, yay! But she liked the Dress of the Nines one a lot better, which is totally understandable, and that's what we were all hoping for in the first place. So I think it went really well. Here's some pictures for that. Here's us setting teeth. Again, aim for good occlusion, but not perfect. Here is my final maxillary denture for Hermie. She loved it. I was very proud. Ross also looked at them. He liked what we did, and she seems very happy with the final products. And here are the ladies together and the final group, Hermes' proud group. Okay, so let's talk a little bit about when things aren't perfect in creating dentures. And we all know that dentures don't last forever, but neither do alveolar bone ridges. Hermie, like I said, she has been edentulous, I think, since she was 17 years old. And her alveolar ridges have resorbed a lot, which has caused her to be a class 3 occlusion, because originally you might be class 1, but then eventually it'll go kind of class 2, resorb back, and then for some reason you end up in a class 3 over time. The upper maxillary resorbs and your lower mandible ends up going, protruding out a little bit further than your maxilla. And that was the case she was in. And along with resorption comes new dentures and relines. And if they don't have implants, you could just do PVS on the whole surface of the denture. Take a new impression. The lab will put new acrylic there, and it'll just fit the new anatomy of the mouth. You can also reline where the implants are. If that changes, you can drill out the implant pieces. And here's a picture of that. Okay, you've drilled out the existing implant pieces, and then eventually you want to fill it in with acrylic and press it on to the new implant spots with the new caps. And here's the final product, and it should fit. Another challenge we were given is we were asked to outline an innovation that we can imagine to improve prosthetics. And something I thought of that could be crazy and not work, but when I was reading the Wiscott and Belser article, it was talking about how there's not just a vertical axis force on teeth, right, down into the alveolar bone, but there's also a lot of lateral forces going on from not just the muscles, but also from mastication. And I was thinking that in the lab section of denture making, before the final acrylic is added, after the wax is melted off, there's that, not the incisal surface of the teeth, but the other side that's showing. If you painted some sort of material, I don't know, maybe some sort of harder silicone on each of the teeth that mimicked the amount of pressure that PDLs could bear, and then put the acrylic on, maybe it could act as some sort of hydraulic or shock absorber, where right now dentures are so rigid that there's a lot of rocking that could happen because the teeth are just stuck directly to acrylic. But the PDL space almost acts like a shock absorber. So if we could create some sort of material in between the acrylic and the tooth to mimic that, I think that it could possibly help from the rocking and the tipping and all the different forces that are being put onto the denture. Who knows? So as you can see, a prosthodontist can wear many hats. They're artists, they're innovative, they're very creative. They have a lot of knowledge on materials and techniques. But at the end of the day, you're a professional. And earlier in the semester, I made a video on what I think professionalism is. And it pretty much just sums up my belief to this day. Here it is. Okay, so you wanted a follow-up video on professionalism and how to make a denture. And I'm just going to add on to what I said before I said dress nicely, treat the patient as if they were on your same level. Don't talk down to them, but talk with them as if they were an equal. There was something else that stood out with me yesterday, and it was having an expert opinion. You are in you are a professional for a reason. You are the best at what you do, and sometimes that requires you to make the ultimate decision on what's best for the patient. I don't remember exactly what it was yesterday, but there was a type of denture that you decided to make for that third gentleman, and you said you made the ultimate decision to use the strongest material, but it compensated for the teeth, I think, staying in the same position. Um, you did offer, if he wanted, to change the teeth and adjust them if he would like, but you had to make that decision to use the stronger material because you thought that that's what he would like. And I think that that's not always a decision that the patients can make because they don't know you know, what is the value in a certain material, and that's something that you have learned for them. So I think that having an expert opinion is also a part of professionalism that is important. And yeah. And that concludes my Prothsfolio. I know you wanted between 10 and 20 minutes, but now you get a bonus 22 minutes of me. I hope you enjoyed it. Thanks for everything.